This is an elderly gentleman with Parkinsonism as well as hypertension and a host of cardiac problems. He also has got primary angle closure glaucoma in this side. He had a chronic angle closure glaucoma in the other eye, for which I had done a combined procedure. And the main area of interest is to show you how I perform the Phaco in this Parkinsonism patient with active head nodding. So here initially I'm just placing my incision. It's a 2.8 millimeter incision, and yes, there is head nodding, there is a lot of movement, but it is a fairly regular rhythmic movement, so you can easily adjust to this surgery. And I have put in my incisions. I then put in HPMC. Mind you, the patient is extremely cooperative. He just cannot help this. So there's no other clue. You just have to adjust. Just be a little careful, but it's not that difficult, believe me. So after putting HPMC, I'm going ahead and fashioning my 5.5 mm rexus. It's more like a 5 mm rexus. Don't make it too big. You don't want to lose your rexus in a case like this. So with my bent 26 gauge needle, using primarily shearing forces, I am fashioning a circular rexus, and that's well done. I then go ahead, decompress the chamber before I actually perform hydrodissection. And normally I would stop with just one wave. In this case I just decided I need to do one more wave. In a narrow angle glaucoma, it's not a good idea to overhydrate the eye. Try to avoid that, but no harm done here in this case. I fill the chamber after the hydrodissection with HPMC, and with the Sinskey hook I rotate this nucleus just to make sure that there are no corticocapsular adhesions, and also that I kick up most of the cortex so that it becomes easier, safer and faster. I then take, this is a grade 2 plus to 3 nuclear sclerosis, a very easy cataract for disassembly. So I just use a Sinskey hook as a chopper, and there I am going ahead. It's a little, may not be difficult, but just different from your regular cases. So here anyway I have managed to get a good first chop, and that's all, and that is a sign of good things to happen, so I'm happy about that. And that's the second chop, that's also good. Very important for you to remain calm in cases like this. That is the most important aspect of this surgery rather than the technique itself. And if you remain calm, it just goes on like a regular case. Don't get perturbed, don't get disturbed by the head nodding. And as you can see, I am getting the segmentation beautifully. Absolutely no problem. And if you notice carefully, the eye is always almost in the center of the field. That shows how cooperative the patient is. Definitely the head nodding is there, which he cannot help, but he is not unnecessarily moving his head around. So it's actually, he's making my job very easy. So once all the segments have done, are done, I keep removing them. I am at 40 ml AFR, 400 millimeters of vacuum. I am in continuous mode, and my bottle height is around 100 centimeters. I don't change my parameters for anything. I will only change my parameters when I if I use the Phaco probe for cortex, which is not a good idea to do in this case. So, but since there is an epinucleus left, I do step down on my parameters and go ahead and bring out the epinucleus. Just engage it, bring it out, and go back into my Phaco mode and take it out. That's it. Once that's done, I go ahead with my bimanual. Now I'm with my irrigation aspiration parameters, which is around 20 ml of AFR and 300 millimeters, 250 to 300 millimeters mercury of vacuum. And you have to remember, this is a narrow angle glaucoma. The anterior chamber is shallow, and you are not very sure of the zonular integrity, so you have to take the necessary and adequate precaution. And I've almost got out all the cortex, just switched hands so that I get out the cortex from the other quadrants as well. And once all the cortex is out, I decide to go ahead and hydro implant this lens. This is a single piece hydrophobic IOL. And very easily I hydro implant this foldable IOL. I just help it along its way into the bag with the Senski hook. And having done that, I then put in my intracameral antibiotic, make sure all the wounds are watertight, perform the bounce test, and conclude the surgery. Thank you so much for your patient watching.